We are live.
Okay. A very good evening to one and all that are present here, and I welcome you all to another edition of the Yosi Journal Club. Before we begin, I would like to introduce Team Yosi to everyone who has tuned in this evening. We consist of a governing council consisting of our president, Dr. Sonal Kalia ma'am, our vice president, Dr. Divakant sir, our secretary, Dr. Karan Bhatia sir, Dr. Avanish Upadhyay, who's the treasurer, and Dr. Nilesh Kumar, who is the joint secretary. The entire team at Yosi is also assisted by 20 executive members from all around the country and abroad. With that out of the way, let us get into the crux of the matter. That is the concept of the Yosi Journal Club, where we learn and grow. This is a platform where young ophthalmologists, fellows, as well as postgraduates present cases from manuscripts that are in peer-reviewed journals for further assessment. So the crux is to assess the existing literature where we define a problem, we specify what the research question is, we define the variables, we discuss the selection of subjects that were chosen, we discuss whether the research design was appropriate or not, we analyze the way in which the data was structured, and we interpret the results in our own way with the Mary format, which I will further elucidate. The format of the Yosi Journal Club is a very interesting one, where for an entire month, a mentee who's chosen, who is a young ophthalmologist, a fellow, or a postgraduate, who's assisted by a mentor in a subspecialty of their choice. They are assisted for 1 month to break down and to discuss the nuances of a research paper that has been published currently in literature. On the day of the journal club, the mentee presents the article, while at the same time, we have a panelist and a research expert who breaks down the article in different formats to make sure that it is elucidated to the audience very lucidly. So coming to the Mary format, this is the way we like to break down the article so that it is easy for us to know what the crux of the matter is and to critically appraise it. This consists of the method of the study, the assignment and the assessment that was in the study, the results of the study, the interpretation that the study had, and the factors that can be extrapolated. This is a step-by-step approach to reading medical evidence. I would like to introduce you to the team Yosi Journal Club led by Dr. Nupur Goel. If you like the format of the Journal Club, you can take a screenshot of this page and your entries are most welcome, and you're most welcome to present in our next edition. Since our very first season, almost 2 years ago, we've had numerous sessions which included glaucoma, endophthalmitis, cataract surgery, ocular oncology, pediatric ophthalmology, oculoplasty, which was last year, glaucoma again, which we repeated last year, followed by retina and pediatric ophthalmology in September and October of last year. And we ended the year last year with cataract and refractive surgery, as well as cornea in December. We once again began the next season of Yosi Journal Club this year with cornea in March. In April, we discussed glaucoma. In May, we discussed retina. In June, we discussed cataract surgery once again. In July, we discussed uvea. In August, we went back to oculoplasty. In September, we had a very special session where our chief guest was Dr. M. Vanati, who's the current editor of the Indian Journal of Ophthalmology. We had a very special session on biostatistics and the statistical part of a research paper. And that brings us once again to the month of November and once again back to glaucoma. Having said that, the article that will be discussed today is Fast Progressors in Glaucoma, Prevalence Based on Global and Central Visual Field Loss. This is from the Ophthalmology Journal by the American Academy of Ophthalmology with an impact factor close to 12. Joining us on the panel today is Dr. Mithun Tulasidas, I'm so sorry for that, who is a cataract and glaucoma specialist. He will be a research expert for this evening. On our panel, we have Dr. Richa Gupta, who is the founder, director, and senior consultant at Sunetram Eye Care in New Delhi. Dr. Karthikeyan M., who is the assistant professor of ophthalmology at the Prasad Center for Sciences at New Delhi. Dr. John David, the glaucoma, cataract, and refractive surgeon at Western Eye Hospital and Chaitanya Eye Hospital in Kochi. Our mentor who has been effortlessly and timelessly guiding our mentee for this entire month is Dr. Arshi Singh, who is a senior resident of glaucoma services at the Guru Nanak Eye Center at Mamsi, New Delhi. And our presenter today and our speaker today is Dr. Shruti Devi S., who has very kindly consented. Finally, a postgraduate at the Chettinad Hospital and Research Institute. My name is Dr. Anujit Paul, and I will be a moderator for this evening. So without further ado, we are done with some introductions. Let us begin with the journal club. Dr. Shruti, I would request you to please share your screen, and you're more than welcome to begin.
Yes. Good evening, everyone. This is Dr. Shruti Devi S., a final year postgraduate from Chettinad Hospital and Research Institute. And topic for today's journal club discussion is on fast progresses in glaucoma, prevalence based on global and central visual field loss. To begin with the basic introduction, the key goal in the clinical management of glaucoma is to prevent the functional disability. And visual field testing, it serves the essential purpose of estimating the current degree and documenting the disease progression, and also helps in understanding the future risk of functional impairment. So small briefing about the perimeter. Visual field tests can be further categorized into the threshold test and the supra-threshold tests. So threshold tests, they include the point patterns being center 30-2, 24-2, 10-2, nasal step, and the macular program. So here, so basically when you see a visual field report, so you see the extent of the visual field which is being tested, the number of the test points, the distance between the 2 points, and the bare area which is present surrounding the fixation spot. So as far as this study is concerned, they'd use the central 24-2 visual field, so which has 54 test locations, and the distance between the 2 points is 6 degrees. And the innermost 4 points are 3 degrees from the fixation spot, so which implies a bare area of 3 degrees around the fixation spot, and the area of testing from the fixation spot is 24 degrees. And Anderson's criteria is basically, it helps us in grading the glaucoma severity and helps in understanding the early localized defects due to glaucoma. And it has 3 parameters, namely the 3 non-X photomas in pattern deviation probability plot with 2 points of P less than 5% and 1 point of P less than 1%, and a pattern standard deviation of a probability of less than 5%, and the glaucoma hemifield test should be in abnormal limits. So question for the audience, what type of tonometry utilizes the invert fit principle for IOP measurement? And the options are Schiot's tonometry, non-contact tonometry, Goldman applanation tonometry, and Perkins tonometry. So 10 seconds is there for you to answer.
So Dr. Ananta Lakshmi CK has replied with GAT. I think you can go ahead.
Yeah, that's the correct answer. And fast progression per se, it's defined as the one which exhibits a decline of -1 decibel per year, decline in the global measure of mean deviation, which is derived at least for the median of 5 visual field tests. And both fast global rates of visual field loss, which is based on the current conventional testing of the central 30 degrees and central involvement of the glaucomatous visual field loss, which involves the macular region, basically the central 10 degree, is strongly associated with the functional disability and poorer vision-related quality of life. So the rationale of this study was to determine the prevalence of the fast progresses based on the measurement of the global and central visual field sensitivities across various thresholds, and also to determine the proportion of patients who are on anti-glaucoma medications who are at a higher risk of functional disability. So materials and methods. So here the first group included patients who were seen at a private ophthalmology clinic in Melbourne, Australia, who were under routine care, and this is a retrospective review. A second group had participants of 2 prospective longitudinal observational studies of visual function and structural changes in glaucoma. Namely, there were 2 groups, DICS, and that is the Diagnostic Innovations in the Glaucoma Study, and the African Descent and Glaucoma Evaluation Study under routine clinical care. And these were conducted at 3 sites, namely the Hamilton Glaucoma Center, the University of California, San Diego, Edward S. Harkness Eye Institute at the Columbia University Medical Center, and third at the Department of Ophthalmology in University of Alabama, Birmingham. So now with respect to the inclusion criteria, in the first group, participants who are more than 18 years of age who had a confirmed diagnosis of glaucoma in at least one eye after comprehensive clinical record review, and individuals with POAG, PACG, and secondary glaucoma were included in the first group. With respect to the second group, the participants should have evidence of glaucomatous optic neuropathy on stereographs and with a history of 3 or more consecutive abnormal visual field test results, and all of them were POAG patients. Ocular systemic conditions, apart from glaucoma, which has a significant impact on the visual field test results like neovascular ARMD, was excluded. And the DICS and the ADAGS, all the participants, they underwent a comprehensive ophthalmic examination at the baseline, which included a medical history review, visual acuity and visual field testing, slit lamp biomicroscopy and fundoscopy, stereoscopic optic disc photography, and intraocular pressure measurements and the gonioscopy. And all the participants were more than 18 years of age with the best corrected visual acuity of 20/40 or better and had open angles on gonioscopy. Now again, a question for the audience. The diagnostic tests used in glaucoma include all except gonioscopy, stereoscopic optic disc photography, visual fields, and OCT angiography. 10 seconds for answering.
So if you know the answer, you can add it in the chat box below. This is for all the audience out there. You can go ahead with the answer, Dr. Shruti.
Okay, the answer is OCT angiography. That's not used as a diagnostic test for glaucoma. Okay. So now, Sita strategy is a algorithm which is inbuilt in the Humphreys visual field analyzer. It makes use of a complex mathematical module to detect the threshold stimulus which is presented at each test location, and also gathers information from other locations, and this is based on the Bayesian probability principle. So for the testing strategy employed in this study was Sita 24-2, and the criteria for the tests to be considered reliable include those tests which had less than or equal to 33% fixation loss and less than 15% false positive errors were considered to be reliable. And the first visual field test results were excluded to minimize the potential impact of the learning effect for the patients. And only those eyes which had more than 5 visual field test results which were reliable were included in this study. And the main outcome measures which were assessed included the mean deviation from the entire 24-2 visual field test, which was assessed on the Humphreys visual field perimeter as a weighted average of the total deviation values, which is a difference in the visual sensitivity from the age expected values. And the mean total deviation of the 12 test locations within the central 10 degrees was MTD10. Another question for the audience. Mutation in which gene is associated with the pseudoexfoliation syndrome?
So another very interesting question. So if anyone in the audience knows the answer, you can just type 1, 2, 3, or 4 in the chat box. Dr. Ananta Lakshmi CK has typed option number 3. Okay,
yeah, it's the LOXL1 gene. Yeah, that's the right answer. Okay. So now with respect to the statistical analysis, so here the outcome measures of rate of mean deviation and the MTD10 change for each eye was assessed using the ordinary least square regression analysis, and the prevalence of eyes which exhibited the slopes which exceeded a different range of cutoffs less than -0.25, -0.5, -0.75, and -1 dB per year, and positive slopes greater than 0.25, 0.5, 0.75, and more than 1 dB per year for both MD and MTD10 was assessed using mixed effects binary logistic regression models to account for the correlation between the two eyes of the same individual. And the prevalence of eyes which exhibited the rate of change exceeding the different probability cutoffs based on the estimated normal distribution of the rate of change in mean deviation and the MTD10 was done to enable a more uniform comparison between both the measures. And these cutoffs included probabilities of less than 5%, less than 2, less than 1, and less than 0.5%. And linear mixed models was used to assess the mean absolute value from the eyes, which exhibited the positive slope to account for the correlation between the two eyes of an individual and between individuals within the same site. So this mean absolute value was further used to calculate the standard deviation and the above mentioned probability cutoffs. And the mixed effect binary logistic regression models was used to detect the prevalence of eyes which exhibited the rate of change exceeding the probability cutoffs. And mixed effects multinomial logistic regression models was used to assess the rate of change in mean deviation or rate of change in the MKD10 or changes in both the measures. One other question for the audience. Which type of glaucoma is caused by leakage of lens protein through the capsule of mature or a hypermature cataract?
So once again, if you are in the audience and you know the answer, you can just type 1, 2, 3, or 4. We'll just give it 5 seconds for everyone to go through the options. So Dr. Purna Shan has typed option 4.
Option?
So as Dr. Shruti, can we have the answer?
Yeah, the answer is phacolytic glaucoma.
Absolutely.
So now moving over to the results. 623 eyes of 461 individuals underwent a median of 7 visual field tests in a median follow-up period of 4.5 years. And the average age of the participants was 66 plus or minus 11 years of age. And 50% of the population were women. A total of 627 eyes, that is 90% of them had primary open-angle glaucoma and 6% had primary angle closure glaucoma. So at the baseline, the median 24-2 visual field mean deviation was 4.07 decibels and pattern standard deviation was 4.51 decibels. So now this bar graph, that is bar graph A, it depicts the distribution at the rate of change for the mean deviation from the entire 24-2 visual field, whereas the second bar graph shows us the mean total deviation of a central 10 degree. As you can see, the median rate of mean deviation was minus 0.2 decibels per year, and the median rate of MKD10 was minus 0.19 dB per year with respect to the MKD10. And table 2, it depicts the prevalence of the glaucomatous eyes with different rates of change in the visual field sensitivity. So these findings, they demonstrate how 28.1% and 12.5% of the eyes showed a negative slope of minus 0.5 and minus 1 dB per year, respectively, in the mean deviation cohort. And 7.9% of eyes showed a positive slope of 0.5 dB per year in the mean deviation cohort. And 29% and 11% of the eyes showed a negative slope of minus 0.5 and minus 1 dB per year in the MKD10 cohort. And 8.5% of the eyes showed a 0.5 dB per year increase in the MKD10 cohort. And table 3, it depicts the prevalence of the glaucomatous eyes with visual field sensitivity decline exceeding different cutoffs based on the estimated normal distribution. And these findings, they demonstrate how 12.7% and 9.1% of the eyes showed a decline in the mean deviation and the MKD10 for a value of a probability cutoff which exceeded 1% based on the estimated normal distribution. And also this table, it examines the proportion of eyes which detected the prevalence of the visual field sensitivity differences either in the mean deviation or in the MKD10 alone or both the measures. So as you can see, with respect to the cutoff of less than 1% based on the estimated normal distribution, 50% showed a decline in both mean deviation and MKD10, whereas only 33% showed a decline in mean deviation and only 17% showed a decline in the MKD10. So now moving on to discussion, and approximately 1 in 8 eyes who were on anti-glaucoma medications across 4 different sites exhibited a fast progression, which was defined as a rate of change in the mean deviation of 1 dB per year decline. And similar proportion of eyes also exhibited a decline in the central 10 degree, and nearly 1 in 3 eyes showed a decline of minus 0.5 dB per year in this region. And this highlights how a proportion of patients who were under treatment for glaucoma showed clinically important rates of central visual field progression, which emphasize the importance of assessing the central region in the clinical management of glaucoma to prevent the functional disability. And with respect to the previous studies, the finding that 12.5% of the eyes in the entire cohort progressed to a decline of minus 1 dB per year was deemed as the fast progressors, which was in the range of 5 to 12% reported in the previous studies with a similar design. And the prevalence of fast progressors in this study was similar to that of the 10% prevalence, which was seen in a cohort of eyes with clinically diagnosed glaucoma across private ophthalmology clinics in Australia. However, this was higher than the prevalence which was reported in the studies in France, which had 11.3%, UK 7.5%, and Canada 5.7%. But the drawback with the previous studies was that it included eyes with ocular hypertension, glaucoma suspects, unaffected eyes of individuals with unilateral glaucoma or combination, which was expected to have a lower prevalence of faster progression than eyes with established glaucoma, as this study included those eyes with established glaucoma. Another question for the audience. Which of the following is a method to improve the medication adherence in glaucoma? A. Reminder caps. B. Medication alerts. C. Simplifying the medication regime. 4. Patient education. 5. All the above.
So once again, you can add the answer in the chat box with the number option. 1, 2, 3, 4, or 5. Dr. Poorna Shan has replied with option number 5.
Yeah.
I think Dr.
All the
Shruti
above. Yes, that's the correct answer. Oh. I'm not able to.
Yeah, the option, if you cannot move the slide, just use the
Yes, sir.
arrow bar.
Yeah. Yes, sir. So now the conclusions put forth by the author was, this was the first study which was conducted to detect the prevalence of central visual field progression in patients diagnosed with glaucoma. And they found out that 11.7% of the eyes had a decline of -1 dB per year with a change in the mean total deviations in the central 10 degrees. And 29% of the eyes showed a decline of -0.5 dB per year. So this decline of -0.5 decibels per year was regarded as a fast progression, and this occurred in the central region. And this study observed that 1 in 3 eyes exhibited such a level of decline. And on comparing visual field progression against thresholds of clinical significance, these results were compared against the thresholds based on the estimated normal distribution of the eyes. And this analysis was undertaken, and the variability of the MTD10 was greater than that of the mean deviation, as the fact that the MTD10 was derived from the 12 out of the 54 test locations. And the measurement variability was 1.30 decibels with respect to the MTD10 and 1.17 decibels for mean deviation. And it also highlights how the progressive decline in the central visual field, it happened in a notable proportion of patients diagnosed with glaucoma, which could not have been detected or missed if only mean deviation values had been considered. So limitations put forth by the author: first, the sample size was smaller compared to the previous studies, which had nearly like thousands of individuals. And patients with primary open glaucoma were included in the DIGS and the ADAGS. And patients with any type of glaucoma were included in the Australia retrospective review, proving the discrepancy. And 1/4 of the eyes underwent a median of 5 visual field tests. And these results were available for analysis, which limited the precision of rate of change while estimating using the ordinary logistic regression analysis. Now, my interpretation of this study, the MARI acronym. So here M stands for method. So here the study question was well defined. However, the sample size was inadequate. A study population, the patients who were diagnosed with glaucoma, they met the eligibility criteria, but they were not uniform in parameters, as the first group had all types of glaucoma and second group had only POAG patients. A study period was also well defined. And study methodology, there was a discrepancy, as one group had retrospective analysis in the Australia group, and the other group had participants who were in the prospective observational study in the DIGS and the ADAGS. And a follow-up period of 5 years was done to determine the glaucomatous progression. And patients were seen at centers which were within the academic setting, and they had more exposure to undergo diagnostic tests frequently than those patients in a non-academic setting. And the tenets of Declaration of Helsinki were followed. And the DIGS in the ADAGS was in adherence with the Health Insurance Portability and Accountability Act. And the measurement of outcome, would have been better had they used the Bayesian linear mix model than the OLS regression approach, which will help in predicting the future mean deviation values. In fact, the SIDA strategy is entirely based on the Bayesian probability principle. And I felt the study group methodology was also not appropriate as there were ethnicity variations between the two groups, as first one had Australian population, the second one had African population. And I also felt the masking was not done appropriately as the first group had retrospective was a retrospective study, and second group had participants of the prospective observational study. And moreover, there was no comment on the structural changes, that is in terms of the disc cupping for the fast progressors. And the first group, they underwent a median of 5 visual field tests, and second group underwent a median of 7 visual field tests. Statistical tests which were employed could have been better, as OLS-based analysis may overestimate the true prevalence of fast progressors on a slightly higher note. So the interpretation is the notable proportion of patients who were diagnosed with glaucoma had changes in central visual field, but not globally. So this necessitates the need for device manufacturers to incorporate a simple to derive metric of mean central visual sensitivity in progression analysis software to help us in guiding the clinical management. And a notable proportion of patients who were on anti-glaucoma medications were indeed fast progressors. So I feel these results cannot be extrapolated for all the populations, and 24-2C and 10-2 visual field testing could have been used in comparison with the central MPD10 values. And there was no clear distinction amongst the defined analysis of POAG versus PACG versus secondary glaucoma with respect to the visual field parameters. So take-home message is, I felt the sample size was inadequate and there were inclusion criteria differences amongst both the groups, and study methodology pattern had discrepancy between both the groups, and the ethnicity variations cannot be generalized to all the population, and there was no comment on the structural disc damage of the patients and target IOP values. And also there was no mention of the number and the class of the anti-glaucoma medications the patients were on, or any history of any filtering surgery priorly done. So thus, 1 in 8 eyes with glaucoma who received routine care showed fast progression based on the global mean deviation values with a rate of -1 decibel per year, and that nearly in 1 in 3 eyes showed a decline of -0.5 decibels per year centrally. Thank you. I'd like to thank my mentor, Dr. Urshi Singh ma'am, who took all efforts in helping me interpret this article and prepare the slides. And I also thank the Yosi team for giving me the opportunity to present in this forum, and special gratitude to Dr. Anujit sir. Thank you.
Thank you so much, Dr. Shruti. I think it was very lucidly explained. Especially, can you unshare your screen, please?
Yes, sir.
So I think it was very lucidly explained, especially for an article like this, which is very statistical heavy and very literature heavy. I think you've done an amazing job. So we will discuss this article going forward. But before that, I would like to call upon Dr. Mithun sir, who is our research expert for this evening. Dr. Mithun is a committed ophthalmologist and an independent researcher working as a cataract and glaucoma specialist. He completed his master's degree from K.S. Hegre Medical Academy in Bangalore, followed by specialty training in cataract, refractive surgery, and glaucoma at the Center for Sight, New Delhi, as well as the Shankara Eye Hospital in Coimbatore. He has won numerous medals at the undergraduate, postgraduate, and fellowship levels, and also has over 50 PubMed Index publications to his credit, has written 7 book chapters and presented over 60 papers in national as well as international conferences. He serves as a journal referee in more than 10 reputed journals, including the European Journal of Ophthalmology, the prestigious Eye and Vision, Scientific Reports, Clinical Ophthalmology at New Zealand, International Ophthalmology, to name a few. He has also secured several awards, including the AIOS Young Researcher Award in 2021, the IGO Gold Award in 2022, the Scientific Round winner at the Science and Fun in Ophthalmology in AIOS 2020, and numerous other awards to his credit. With that, sir, I invite you to discuss the statistical aspects of this paper.
Thank you, Anujit, for the kind introduction. So I'll just share my screen.
Absolutely.
Is it visible?
Yes, yes, it's visible in full screen.
Yeah. So good evening all, and thank you, Shruti, for a wonderful presentation and critical analysis of the manuscript. So I'll be talking about my part of the session, that is the statistical critic. So before starting my talk, I would like to say that as we all are basically a practicing clinical ophthalmologist, what we basically need to know in statistics is the basics of statistics. Because yes, obviously we can do the simple statistical methods like students test and all those things, but when it comes to complex methods, it is difficult to do it on our own. So what we basically need to know is how to choose a right statistical test. Or when we are critiquing a paper, we need to know whether they have used the proper statistical methods for the analysis. So that is what the basic concept of my today's talk. So I will try to make things as simple as possible because in the present study, the authors have used a regression model for the statistical analysis. So a regression analysis is little complex when it comes to the statistics. So with a short span of time, I can't explain all the things, but I have tried to make it as simple as possible. So this I have already talked about in the last biostatistics webinar. So when you are planning to apply a statistical test, you have to answer these 5 questions. Now I'll be discussing these 5 questions in relation to the present study. So what was the basic question of the study? So here, whether they are comparing a difference or checking a relationship. So neither of these two. But yeah, definitely they were actually trying to predict the rate of change of the mean deviation over a time, or they are trying to see the proportion or the percentage of the population which will come under fast progressors. So basically, it is more like checking a relationship when we broadly say. So the question here is basically checking a relationship. Now comes the scale of the data. So mostly the data will have 3 scales, either a continuous, ordinal, or nominal scale. So a continuous scale is basically a numerical scale, that is basically numbers. Whatever in numerical order or number is basically continuous. And an ordinal scale means in categories. Categories means in specific groups. So like a staging of glaucoma, or like if you see in the present study, what they have done, like grouping the range of cutoffs, that is 0.2 decibel, 0.25 decibel per year, 0.5 decibel per year. That is basically a category. So in an order. So that comes under an ordinal data. Similarly, when they have made the probability cutoff, that is less than 5%, 2%, 1%, again it will come under ordinal data. Now, the third form of data is nominal. That is basically yes or no, whether the patient has glaucoma or no glaucoma, or male or female. Like that is nominal data. In this study, I don't think we don't have a nominal data, but we do have continuous and ordinal data. Then yes, definitely you have to look at the normality of the data, whether the data is normally distributed. So even though they have shown the bar charts for the median values, that is kind of uh, a normality test for data distribution when you do a histogram plotting. Then whether the design is paired or unpaired, here it is a paired design. Paired design basically means there is only one group. So they have considered a group and they're just seeing the rate of change of mean deviation in that particular group. And the number of groups is basically the number of parameters we are considering. Here we are basically looking at mean deviation and mean total deviation. So this is the basics of regression analysis. So there will be a dependent variable and an independent variable. This is mainly in relation to the outcomes. So basically, we are more worried about the independent variable rather than the dependent variable. So the dependent variable can be anything. It can be continuous, ordinal, or nominal. But the test varies depending upon the independent variable. So when the independent variable is continuous, simple, we use a linear regression. So a linear regression is meant for continuous independent variable. Whereas if the independent variable is ordinal or nominal, we go for a logistic regression. So logistic regression is for ordinal or nominal parameter, and a linear regression is for a continuous parameter. Now, before criticizing the statistical analysis of the paper, I would like to share these two concepts. That is, in a regression model or in a mixed model, we need to know what is a fixed effect and what is a random effect. So fixed effect is basically the parameters of primary interest. So primary interest in the sense the main outcome measures what we are looking at. So in the present study, obviously the mean deviation and the mean total deviation in the central 10 degrees are fixed effects. Means that are the parameters of primary interest. Now, there'll be something known as random effects, which is basically kind of invisible when you read a paper because they are not of primary interest. That is basically an inter-subject variation or an inter-eye variation or an inter-site variation. So here, as you can see, the study was done in different sites. So there can be a slight kind of variation between the sites. And also when you consider n number of individuals, there can be differences between the individuals and again between one eye and the other eye. So we need to know these two effects, that is fixed effects and random effects, when we talk about a regression model. So when we consider only fixed effect, it is like a simple regression model. However, when we consider both fixed effects and random effects, then we call it as a mixed regression model. Now, just briefly explaining the tests they have used in the study. So first one is basically the authors have assessed the rate of mean deviation and mean total deviation for each eye. So as you can see here, the independent variable or the variable is a continuous variable. Mean deviation and mean total deviation is a numerical form. So basically they have used the ordinary least square regression model. That is in simple words a form of linear regression model. So that is very clean and simple. So there is no confusion regarding that. Now, what they have done is they have categorized it into different range of cutoffs, that is less than 0.25 decibel per year, 0.5, 0.75, and 1. So now the variable became categorical. It is no more a continuous variable. It is no more a numerical continuous variable. So it is basically an ordinal variable. So definitely the regression method will become a logistic regression. Now, what is binary? Binary is basically when the variables are less than 3. So here, obviously, we are considering only two variables, that is mean deviation and mean total deviation. So there are only two variables, so a binary regression model applies. Mixed effect, like I said, when you consider random effects. So in the first analysis, they have used only simple linear regression because they have not assessed for any correlation between the two eyes or between the individuals. Whereas when it came to the categorical analysis, they have done a correlation between two eyes of an individual. So that goes to a mixed effect model. Now, linear mixed model they have used to calculate the mean absolute value for normal distribution. So basically, if you want to have a probability cutoff, that is 5%, 2%, 1%, like how we see in a Humphrey perimeter and octopus perimeter, we need to have a normal data. So the machines already have this normal data, but when we are doing a study, we need to find this probability cutoffs based on a normal distribution. So how to find a normal distribution? So as you can see in the figure 1, they have shown a histogram plotting where almost 50% of the eyes didn't show any decline, means they didn't progress. So they have considered those 50% of the slope as normal distribution. Now, when there is no decline, the mean value is basically 0 when you add everything. And you have to get the standard deviation to know the probability cutoff. So the probability cutoffs are based on the standard deviation. So in order to get the standard deviation, you need to calculate the mean absolute value and multiply it by square root of pi by 2, which they have explained properly in the statistical methods. So for that, again, you need to use a linear regression model. So the same regression model is used in all the softwares when it comes to Humphrey, Octopus, or whatever kind of visual field testing. So here mean value is again a numerical one. So they have used a linear regression model. And when you have to correlate it between two eyes and between individuals, you have to go for a mixed model. Now, again, when they have made the probability cutoff, that is 5%, 2%, 1%, 0.5%, it became an ordinal data. It is no more a continuous data. So again, a logistic regression should be applied. Again, binary model because there are only two parameters. Then the mixed effects because again they have assessed the correlation between two eyes and between individuals within the same set. Now the last method they have applied is the mixed effect multinomial logistic regression. So here the only difference comes is the multinomial. So multinomial means if the parameter or the measure, outcome measure which we are analyzing is more than or equal to 3. So usually they have in the previous models, they have analyzed only mean deviation and mean total deviation within the 10 degrees. Whereas in this particular analysis, they have assessed the rate of change on either mean deviation or mean total deviation or both. So there are actually three parameters. So that makes it multinomial. And again, the same concept when you are assessing between these, that is a mixed effect. So this is how actually they have applied the statistical test in the present study. And if someone asks me, I would say as a critic, you can say, yeah, definitely there are better statistical approaches like a Bayesian approach, which you can apply, which might give more meaningful results. But as an author, as someone who even publishes paper, I think they have used the appropriate statistical methods because these are the simple methods which any statistician or any academician would initially prefer to use. Now, a small note on the Bayesian approach, again the same which the authors have mentioned in the limitations. So they are told a Bayesian approach might be better when compared to an ordinary least square regression method because an OLS method might overestimate the results. But a Bayesian approach is not that great as well because Bayesian approach needs a few data which might bias the results okay. So a Bayesian approach basically needs a prior distribution. So it is a little complex to make it understand in a very short time. But a prior distribution basically means you need to know the external factors. So when you know more about the subjects, like how Shruti has mentioned in the limitations, like if you know whether the staging of the glaucoma or if you know what was IOP before the progression happened. So if you know more external factors about the subject, that is what we call as prior distributions, then only it is possible to do a Bayesian approach. Because a Bayesian approach consider both fixed and random effects as estimated parameters, means they need a proper pattern for the variation between the eyes or the subjects. And usually Bayesian approach is applied when the sample size is small. Though the present study has a small sample size compared to the existing literature studies, obviously, sample size of more than 600 is not very small, I feel. And a Bayesian approach is little more advanced and little more challenging to perform. It's not easy like how you perform a simple or a mixed model regression analysis. So a Bayesian approach, yeah, definitely is theoretically better than a simple linear regression model. But practically speaking, I would say in this study, even linear regression with a logistic regression mixed effect model would give appropriate results. Thank you. Thank you for a kind attention.
Thank you so much, sir. A lot of statistics, very simplified for.
It's
With that, I'll just share my.
to cover the regression analysis in a short.
Absolutely, absolutely. But you've done a fantastic job.
Okay.
With that, I'd like to invite Dr. Richa Gupta, madam. Dr. Richa Gupta is the founder, director, and senior consultant at the Sunetram Eye Care Hospital in New Delhi. She has completed her MS in ophthalmology from the Kasturba Medical College in Mangalore, where she secured a gold medal and pursued a glaucoma fellowship at Shankar Nethralaya, Chennai. She has worked as a senior consultant at the Shroff Charity Eye Hospital and CL Gupta Eye Institute, and is also in the Department of Medical Education, FAICO Institute. Ma'am, if you are there, I believe ma'am is traveling, so she's having a bit of connection issues. I don't see her on the chat. So in the meantime, we'll just move on to the next speaker. I would like to invite Dr. Karthikeyan. Dr. Karthikeyan works as an assistant professor of ophthalmology at the RP Center, New Delhi, AIMS. He has over 70 research papers and 4 chapters with a lot of citations, 7 of which are high index, and is currently serving as an executive member at Yosi. Dr. Karthikeyan, I would like to invite you to share the negative aspects of today's paper.
Okay, good evening, everyone. I first of all thank the team Yosi for giving me this opportunity. And Doctor, can you hear me? Am I audible?
Yes, sir.
Yeah. And Dr. Sridhi has explained the article very well. and Dr. Mithun has explained the statistical aspect very well. Now, coming on to the negative aspect of the study, one thing is one arm of the study had a retrospective data, and another thing is they added all types of glaucoma. They should have ideally taken only primary open angle glaucoma and did a study. And for the inclusion exclusion criteria, they didn't mention anything about the false negative errors. What cutoff did they take? And they have not mentioned what was the IOP level of the patients. Was the target IOP achieved? And they should have ideally assessed the IOP difference in IOP control in between the fast progressors and the normal non-progressors. And they should have also see whether the visual acuity change was noted in the fast progressor. They have said that 1/8 of the patient, based on the total global points, had a fast progression, and based on the central 12 points, around 1/3 of the patient had fast progression. It would be better if they had assessed the risk factors or analyzed the risk factors for this fast progression, and we'd have be cautiously observing those patients with high risk factors, and we could have had a better IOP control in this patient. Like some of the studies, previous study says that risk factors for faster progressions like older age, like Kim et al. Study said that older age and patient with pseudoexposition syndrome, higher peak IOP, and a mean deviation or lower CCT, or these were the risk factors for faster progression. And another aspect is they have taken from the 24-2, they have taken central 10-degree points and they analyzed the MD center 12 points. They analyzed the mean deviation of it. It has they could have ideally done a separate 10-2 test. It would have had around 68 points. The more the points, there will be less variability. This could have given a better understanding of the mean deviation change in this patient. And they have also said that some patients showed only change in central 10-2 fast, according to central 12 points, they had a fast progression, but they were not seen in the global one. They should have identified what the profile of this patient who had central 12 central visual field progression compared to the global progression, and it should have a risk factor analyze the risk factors for the same. It would have been helpful if they have done that. And thank you.
Thank you, Dr. Karthikeyan. And I agree with you with the sample size collection and the disparity that you mentioned over there. With that, I'd like to move on to our third panelist for this evening, who is none other than Dr. John Davis Akara. Dr. John Davis Akara is a glaucoma and cataract and refractive surgeon at the Western Eye Hospital and Chaitanya Eye Hospital, Kochi. He's a former glaucoma consultant at Sri Ramachandra Medical College, Chennai, and the Little Flower Hospital in Angamali. He has completed his MBBS and his MS from JIPMER and his glaucoma fellowship from Arvinda Hospital, Pondicherry, followed by the Ratan Tata Advanced Cataract Fellowship from Shankar Nethralaya. He has presented in numerous state, national, and international conferences. However, he's known to be a pioneer and an innovator with numerous innovations, including the foldable fundoscope, virtual reality perimetry, smartphone ophthalmic imaging, augmented reality, artificial intelligence, Raspberry Pi-based surgical recorders, etc. It goes without saying, with so many innovations to his credit, he also has numerous publications in various journals, both national and international. He's also known for his ophthalmic applications, which are now on the App Store and the Play Store, some of which is iGrader and I Know Tamil, as well as the 3D Atlas in ophthalmology. With that, sir, I'd like to invite you to share your thoughts on the recent advances in this topic.
Thank you, Anujit. Thank you for the kind introduction. And thank you to Yosi for organizing such a very useful program. And I'm very impressed that you're using the MARI approach. And Dr. Sengupta, Dr. Sabyasachi Sengupta had taught us that when he was there in JIPMER for a short time, but nowhere else, nobody else was using it properly. So I'll be talking about some newer advances in this field. As you have seen, there was a lot of confusion regarding the 24-2 and the 10-2. Like we should do both to know the peripheral field changes as well as the central field changes. And so this 24-2C from Zeiss on their Humphrey field analyzers, it is supposed to take care of both. It has extra points in the center so that the 3-degree lost space in the center is avoided, and you can capture the central field effects also here. So that is the 24-2C. And if we are worried about taking more time on the field test, which is a major complaint that patients have, of course, they have the Sita faster strategy, which they have a few publications showing that it is as good as the Sita fast and comparable results. And if it is a 24-2 with Sita faster, you can capture the central visual field effects also. So that is what they suggest as a newer approach. And everywhere now, AI is taking over. So artificial intelligence is being used for everything. And there have been several publications, some of them which do pre-perimetric visual field um, diagnosis of glaucoma. So that is using perimetry, they do pre-perimetric visual field diagnosis of glaucoma. That is because the AI is able to pick out minute changes which humans may not be able to pick up very easily. It can differentiate various visual field defects. There have been studies which shows that it can analyze the visual field defects in detail, and it can also analyze frequency doubling perimetry, and also it can analyze the progression of patterns so that even slow progression can be detected. We don't have to wait for an obvious progression change. Then there are some studies which try to predict the future. So what they mean is there was a deep learning system which was trained with 32,000 odd visual fields, which was able to predict the future visual fields of a new patient based on their IOP. So this one was able to predict for up to 5.5 years, and here they showed what the actual visual field progression was like and what the AI predicted the visual field progression would be like. So that is also something which is very much available in the near future. Then there was no means to check perimetry in very small children. So LV Prasad Eye Institute, they had developed a pediatric perimeter, which is basically a hemispherical dome, which had stimuli in different parts of the dome, and an infrared camera to look at the infant, and it would be able to put a stimuli in different parts of the hemisphere and look for a response from the baby. So this was a pediatric perimeter. It gives a rough estimate of the visual field extent of infants. Then, of course, there are lots of alternative perimetry methods. It started with laptop and desktop perimetry. There was one from keepyoursight.org, which was called Peristat, which was by serial innovator, the innovator behind iPort, MyPort, and all those innovations from keepyoursight.org. Then there is Ice Cream, which was also a desktop-based Windows program which you could download, install on your laptop, and do perimetry. But these were very simple tests. They did only supra-threshold screening, and there was no proper eye tracking. Then there was the tablet-based perimetries. There was the iPad-based Visual Fields Easy, which was later developed into the Melbourne Rapid Fields, which is now having eye tracking and all that built in. Then there was another one called Eye Catcher, which was a very simple screening which uses the camera to look at the patient's eye movements. So if the patient moves the eye in response to a stimulus, it would accept it as a patient seeing the stimulus. So it was very simple to do the test, but it was not very accurate. Then in Arvind Hospital Pondicherry, we developed the Periscreener, which was basically a smartphone inside on a very low cost virtual reality headset. So we control that with the Bluetooth clicker, the Bluetooth camera clicker, and we were able to do basic visual fields. So this was from that. Then, of course, Remedio had built upon the idea, and they brought about their CFA and then later the Intelligent Vision Analyzer. And Elizar also has their own virtual reality perimeter now. And there are many more from MMD, also the Melbourne Rapid Fields, VF2000, Vivid Vision, VR eCloud, and so many more. Last few years, there are so many virtual reality perimeters. One last thing which is not yet covered. So this is all the virtual reality perimeters. One last thing which was not yet covered was the unreliability of the patient response. So then there was the N-goggle, which uses the brain-computer interface for the patient response. The patient doesn't have to say anything, doesn't have to click anything. It uses a multifocal steady-state VEP response to see if the patient has seen the stimulus. So patient just has to look straight ahead and the perimetry is there. So these are all the latest advancements in this field. Thank you.
Thank you so much, sir. I think you've shown us a lot of things which are mind-boggling that is going on right now. So that brings us to the end of the panelist discussion. If anyone in the audience has some questions, I would like to invite them to add it to the chat box. Meanwhile, last but not the least, I would like to invite our monthly mentor for this month, Dr. Arshi Singh. Dr. Arshi Singh has completed her MBBS from AIIMS, followed by her DNB from LBPF, followed by her FICO, and is currently a senior resident of Glaucoma Services at Guru Nanak Eye Care Institute, MAMC, in New Delhi. She has a lot of international and national journal publications to her repute and has presented in numerous state and international conferences. Besides ophthalmology, she has a passion for music and reading. Dr. Arshi, I'd like to invite you to summarize the topic as well as this evening for everyone. You're muted, Dr. Arshi. You're muted. Dr. Arshi, you are muted. Can you just unmute yourself?
I'm sorry, can you hear me now?
Absolutely.
Thank you for a wonderful discussion today. It was very enjoyable to mentor Shruti, and I thank Yosi for this opportunity. As we just discussed, I think this study would have been better if they had a more homogeneous population set, especially if they had actually separated the OAG versus the ACG group, or the NTG versus the OAG, because NTG is known to have a steeper visual field defect difference over time. But I thought it was interesting how they brought out the fact that there's a role of checking the central points even in early damage. So most of the patients included were the ones with mild to moderate glaucoma. And that brings to question that is there a role of doing a 24-2C or a 10-2 in such patients? Or actually correlating this with the structural damages seen on or as we discussed with the stereoscopic disc imaging, well analyzed with statistically sound data. And what I took home from this was that this is assuming that all the patients who were enrolled within the study had a well-controlled intraocular pressure on medications. They still had progression which was faster than normal in 1 out of 8 patients. Even if we are saying that the Bayesian analysis would give us would give us a better number, we're still looking at a number of patients which have progression despite controlled pressures. So which brings us to the question again, that clinically, how frequently do we need to follow these patients up? And what sort of a baseline of target IOP are we looking at? So a lot of questions that this article raised, and overall a great discussion from everyone. Thank you.
Thank you so much, ma'am. With that, I think we have come towards the end of this webinar. Before ending, I would like to extend our gratitude to all the panelists, as well as the mentor, the research expert, as well as the mentee. I'd like to present a certificate of appreciation to Dr. Shruti Devi, to Dr. Arshi for being a very generous and a very patient monthly mentor for this entire month. Dr. Mithun for being the research expert, Dr. Richa Gupta for being a panelist, Dr. Karthikeyan for being a panelist, and Dr. John Davis Akara for being a panelist. I would like to take this opportunity to invite everyone for our next Journal Club session, which is in December, which is going to be on cataract surgery. Once again, if you enjoyed this Journal Club, you are more than free to participate. You can take a screenshot of this page and send us your entry, and we'll be more than happy to have you. Once again, I'd like to thank, last but not the least, Dr. Nupur ma'am for all her effort in the back-end section of this Journal Club. Thank you, everyone, and a very good night. Ma'am, if you are there,